happen during the neck dissection. So these are the most common nerves which we encounter when we are doing the neck dissection. So we'll be going through this in my presentation. This is the first nerve which we encounter during the neck dissection, greater auricular nerve. It's a sensory nerve and it arises from C2 and C3. It ascends along the sternocleidomastoid and it is lateral to the external jugular vein, and it divides into two divisions, anterior and posterior division. So as said, it is a sensory nerve. It supplies to the skin overlying the parotid. The anterior division supplies the skin overlying the parotid, and whereas the posterior division supplies the ear lobule and antitragus. So these are the expected variations of the division of the greater auricular nerve. Now, most often the division happens in the upper one-third, where it divides into anterior and posterior division. So sometimes it can divide in the middle and in the lower divisions, or sometimes there couldn't be any divisions. So this we need to keep it in mind when we are planning for any flap raising and all. So most often the incidence of this is unnoticed, and sometimes the range is around 13 to 40% has been published. But the most often this complication can happen when you are placing the incision. So we need to have a proper depth perception when you are placing the incision, because we are all used to raise the subplatysmal flaps. But when you go posteriorly, the subcutaneous plane, just below the subcutaneous plane, we have the external jugular vein and we have this greater auricular nerve. So because of this lack of platysmal cover or improper tracing, we tend to injure this now, especially when you are doing the modified radical neck dissection or when we are doing the PMMC. We tend to remove this sternocleidomastoid muscle.
और पोडियम ಅಲ್ಲಿ ಮಾತಾಡೋದು ಬರ್ತಾ ಇಲ್ಲ.
Some audio.
So what happens when you damage this? So there will be a lack of sensation or lack of feeling. With time, it decreases the symptoms, but always make an every attempt to preserve this. Next, this is the nerve which we encounter after when we are proceeding with the neck dissection. This is the marginal or the cervical branch, this is the second branch, what we encounter during the neck dissection. So this is the course of this marginal mandibular nerve. So when it exits the parotid anterior and inferiorly at the angle of mandible, it pierces the investing layer of the deep cervical fascia. It traverses anteriorly, it crosses the facial vessels, and it goes beneath the platysma to enter. This is the usual course of the marginal mandibular nerve with minimal variations in few millimeters. Now, these are the expected variations which can happen in the course of the marginal mandibular nerve. It can go sometimes as low at the posterior belly of digastric or sometimes 2 centimeters above the angle of mandible. So this we need to keep it in mind when we are tracing the marginal mandibular nerve. Now, what is the main supply of this marginal mandibular nerve? It usually supplies the depressors of the lip. So the depressor labii inferioris muscle and the depressor angulae oris muscle. Apart from it, it supplies the mentalis, whereas the cervical branch supplies the platysma. Now there have been varied techniques which have been described for identification and preservation of the marginal mandibular nerve, starting from sandwich technique, Hayes-Martin maneuver. Most of us follow this, and sometimes the parotid masseteric fascia or pterygomasseteric sling approach. Now you can see this in the picture. We have exposed the raised flap, raised the subplatysmal flap. We kept the flaps properly by raising the subplatysmal flap. No thick flap has been raised, and we have incised the investing layer of the deep cervical fascia, and we can see this marginal mandibular nerve. The minute we see this marginal mandibular nerve, try to trace it anteriorly. Avoid any monopolar. Use cold dissection itself. So you can trace the nerve completely. You can see it completely going below the platysma. Then you decide, like, we can make sure that the nerve has been traced completely. So what are the potential sites where we can injure the marginal mandibular nerve? One, at the angle of the mandible where it pierces the investing layer of the deep cervical fascia, and the other side is where it crosses the facial vessels. So sometimes we can have this node of star or the perifacial group of lymph nodes. So this is the other common site where we can damage the marginal mandibular nerve. And this is one of the area where we can damage it, the submandibular triangle. Now we all tend to start with the level 1A neck dissection. We finish the level 1A neck dissection and blindly come to this submandibular triangle area. Now we assume that the nerve has crossed and we just dissect it here and damage the nerve at its entry point. We think that we have preserved the nerve, but the nerve gets damaged at its entry point. So once you raise the flap, start 1A, but don't come to the 1B until you trace the marginal mandibular nerve completely. Now, what happens when there is an injury to the marginal mandibular nerve? What is the sequelae of this injury is this lower lip depressor palsy and lip eversion weakness. So what happens is there will be a deviation in the angle of mouth and drooling. Now let us come into this. What makes us feel happiness is this expression of happiness is smile. So the Rubens has classified the smile into 3 types: Mona Lisa smile, canine, and the full denture smile. What happens in the Mona Lisa smile is this elevators in the form of zygomaticus major are activated, whereas the levator labii superioris is activated in the canine smile. Now all the muscles are equally activated in the full denture, where the elevators and depressors are equally activated. So this smile is the one which is most affected with the palsy to the marginal mandibular nerve. What is the difference between these two? Like we can make a difference in the marginal paresis compared to the cervical branch. In the marginal paresis, as seen earlier, the depressors get paralyzed, and along with that the mentalis. So because of this loss of mentalis, there will be an asymmetric pouting, and we can see it in the next picture. But whereas the cervical branch, if you sacrifice, there will be a weakness of the lip depressors, but the pouting will be intact. Now this is the classical example of the marginal paresis versus the cervical branch. In the marginal paresis, you can see the angle of mouth deviation, and when you ask the patient to pout, the eversion is an issue. You can make out the vermilion border here. We cannot see the vermilion border. So this is the classical example of marginal mandibular nerve palsy. But whereas when it comes to the cervical, there will be a weakness in the branch, but pouting is intact. Do we have any evidence to say the role of any intraoperative nerve monitor? Yes, intraoperative nerve monitor has been a practice changing for head and neck malignancies, especially when you deal with thyroid and parotid. So Tirelli et al. Has proposed a prospective study. They have done it, and they found that in IONM group, less than 5% of the patients were having the paralysis of the marginal nerve. Now, this has been studied even in Tata Memorial Hospital. The results are yet to be published. So how does it help is, it helps in early identification. You can map the course, and you can evaluate and prognosticate the nerve function at the end of the procedure, and you can reduce the incidence of temporary and permanent palsy. So how do we manage it? Simple neuropraxia, there is sort of a demyelination conduction block, it settles down. But to settle down, you need to start the early rehabilitation. There have been described techniques in the form of dynamic and static procedures. Probably this cannot be followed in terms of neck dissection, but still there are options. So there have been a variety of rehabilitation exercises which have been suggested, ranging from external massage, smile expression, sucking and puffing exercises. So you need to start this rehabilitation if you suspect any sort of a neuropraxia. You feel that you have preserved the anatomical continuity, but there is some sort of paresis, start early rehabilitation. Now, there has been a randomized control trial which has been done in terms of parotidectomies. So what is the effectiveness of facial therapy exercises when you start it early? They found that the rehabilitation therapy with mirror facial exercises, when performed autonomously at home, they were equally effective for post-operative functional recovery. Now we have been discussing about the marginal mandibular nerve. Is it confined to preserve the marginal mandibular nerve in early lesions so that in the advanced lesions we can sacrifice the nerve? Probably no. This would be the outcome of the patients when the patients come to the follow-up after 2 years. You see this patients having cosmetic disfigurement, functional disfigurement in the form of a drooling and all. So always make every attempt to preserve the nerve even in the advanced cases. So this would be the outcome even in the advanced cases. This is the case we did in lips, avoided a lip split, but it was a central placed incision. So at the end, we would like to clearly understand the anatomy, place the incisions properly, preserve the nerve, and rehabilitate early. Now when we are done with the marginal mandibular nerve dissection and we have done 1B, the next, when we go to this level 1B in this area or level 2, this is the nerve which we encounter, the hypoglossal nerve. The risk to the hypoglossal injury is around less than 5%. And when the hypoglossal nerve, it exits the hypoglossal canal, it traverses in the carotid sheath, it goes beyond the vagus nerve, and at the bifurcation of the carotid artery, somewhere here it turns slightly sharp so that it goes below the digastric posterior belly and below the mylohyoid. So when you have a gross extranodal extension in the level 2, this is the area where you can damage or sacrifice or injury to the hypoglossal nerve. Now we have been performing the neck dissection at level 1B. So you'll be seeing this lingual nerve. submandibular ganglion, and the hypoglossal nerve. Along with these nerves, you have an accompanying hypoglossal or short renine veins. So you need to identify the proper plane of dissection when you're doing this deep lobe of submandibular gland. Otherwise, you end up in bleeding, and we try to bipolarize or do something, the nerve goes into the praxia. So these are the sequelae: hypoglossal nerve, ipsilateral palsy of the tongue, which can lead to the problems related to the food intake and speech articulation. When the lingual nerve, sometimes there will be chances of injury to the lingual nerve in neck dissection. It leads to the numbness and loss of taste in the anterior two-third of tongue. When we are done with this level 1 neck dissection, when we raise this sternocleidomastoid, this is the nerve which we encounter, the spinal accessory nerve. So as being discussed about the spinal accessory nerve, so spinal accessory nerve is the pure motor nerve and it supplies the sternocleidomastoid and the trapezius. Now there are certain landmarks, there are variety techniques described for identification of the spinal accessory nerve in the anterior triangle. So when you expose the spinal axis, when you try to search for the spinal accessory nerve, when we retract the sternocleidomastoid, you have a plane between the sternocleidomastoid and the posterior belly of digastric. We don't need to search for the nerve in a plane above this. So always try to find the nerve below this. So this has been published in way back in 2007 from Tata Memorial. So this is a constant vein which drains the sternocleidomastoid muscle to the pharyngeal plexus. So just below it, somewhere around 2 millimeters around, if you start searching the nerve, you'll identify this nerve. Now there are certain landmarks for identification in the posterior aspect when you're doing with the posterior triangle. Now this is the common point which we all know. This is the Ebbs point, and this Ebbs point marks the confluence of all the cervical nerves, and just 1 centimeter above and all, you identify the spinal accessory nerve and you can trace it. And there have been certain landmarks published in the form of like 5 centimeters above the clavicle, or sometimes they gave a long back, like when you draw a line from the angle of mandible from here to the mastoid, and when you draw a perpendicular, this coincides with the spinal accessory nerve. So what are the predisposing, or when the nerve is at risk? When you're doing level 2B, or when you're doing the level 5 clearance, or when you're doing the posterior triangle clearance. Even in the selective neck dissection, the chances of injury are there because of the traction or ischemic injuries. So the more vulnerable course would be in the level 5. So we need to understand what happens with the level 5. Now we have seen this, the common trunk, it gives 2 branches. One, the branch to the sternocleidomastoid, and the other one is the trapezius branch. So in type 1 branching, most of the times, at the posterior border of the sternocleidomastoid, you have this branching pattern, and it is, the level of this branching is different from the cervical rootlets. But in type 2 and type 3, the chances of injury are high, especially in type 3, which can course along with and blend with the cervical rootlets, and we assume it to be a rootlet and we sacrifice them. So what are the sequelae of the spinal accessory nerve injury? It's a motor nerve. So there will be a paralysis of the sternocleidomastoid muscle and trapezius. So the patient experiences the pain with limited abduction of shoulder and scapular flaring. So this is the classical example where you can see a shoulder drop. Now when you see this, at the distance between the inferior border of the scapula to the midline is increased in the sacrifice side. So why this shoulder dysfunction happens is because of the loss of the biomechanical balance between the glenohumeral and scapulothoracic joint. Initially in the post-operative period, when you sacrifice this, the patient experiences the pain, sometimes the heaviness of arm, inability to lift the shoulder girdle, and inability to abduct the arm. Later on, it leads to the sequelae in the form of a shoulder droop, atrophic trapeziitis, and adhesive capsulitis. So similarly, the role of intraoperative nerve monitoring again has been studied in preserving the lesions in the spinal accessory nerve during the functional leg dissection. And IONM has reduced the incidence of transient palsy, and no permanent palsies were recorded in this study group. So it could initiate the need for early rehabilitation. Now in the post-operative period, you can assess with the constant score or SPADI score. It's both the blend of pain and also the range of shoulder movements have been assessed. So prevention, or so what has the early rehabilitation does is it relieves the pain and stiffness so that it prevents the capsular ligament stiffness. The abduction can be better. Now the next nerve which we encounter after doing this is the phrenic nerve. Phrenic nerve, this is one of the longest branches of the cervical plexus, It has the motor supply to the diaphragm, apart from the sensory and the sensory-proprioceptive supply to the pericardium. It arises at the lateral border of the scalene and it passes deep to the prevertebral fascia. Now you can see this level of the phrenic nerve, it is way below the prevertebral fascia. So the minute you are above the prevertebral fascia, we are safe. So when can we injure this? The incidence is around 1 to 8%, and the injury can happen when you are tracing the ascending branch of the transverse cervical. When we mess up with this, when we try to bipolarize or clip it, when there is a sort of a bleeding, the chances of injury are high. And even the same when you do for the kyleak repair. So when you encounter the kyleak, expose the planes properly, identify the carotid, identify the phrenic nerve, then start repairing the kyleak. So this can be seen when you are, especially in the bulky lower leg nodes. So this is the sequelae of this. So there will be paralysis of the diaphragm, which can be manifested in the X-ray. There are certain signs which have been proposed where there will be an elevation of the affected side of the diaphragm with diminished absent or paradoxical movement of the diaphragm. And in advanced cases like when you have the severe complications, there will be a mediastinal shift. So usually it is unnoticed, but sometimes the symptoms can happen because of the respiratory or cardiac or GI related issues, and it depends upon the age and pre-existing pulmonary complications. So why these respiratory complications happen is because of the atelectasis or reduction in the lung space. The cardiac complications are very rare. But it can happen when there is a displacement of the mediastinum or mediastinal flutter. The GI complications which are uncommonly seen, but it can happen because of the displacement of the cranial abdominal contents. Now when we have moved from the radical neck dissection era to the selective neck dissection and super selective neck dissection, these are the most commonly battered nerves. So unrespected nerves in the radical neck dissection era. What happens is the cervical plexus, the patient usually experiences the post-operative or unexplained neck pain. Unpleasant abnormal sensations can happen, and sometimes even the patients develop the cervical neuromas. These are nothing but they present as a painful palpable subcutaneous nodule. It could be because of amputation neuromas, and the pain can be diffused or localized. Coming to the sympathetic and the vagus nerve, the incidence to injury this things extremely rare when you're dealing with gross N3B nodes in the lower neck nodes. Now we need to understand the course of the vagus nerve. Vagus nerve lies within the carotid sheath and it is posterior and medial to the internal jugular vein. So whenever we want to ligate the IJV, we have to have a proper exposure. Separate the vagus, separate the IJV, expose it properly, then only do your transfixation stitches. Otherwise we end up in damaging the vagal. And we can see the course of this, the relationship of this vagus nerve. It is lying between the IJV and carotid, and sympathetic injuries are very rare and extremely rare. This lies very much medial to the carotid. But expected complex, some reported incidences are there. It can lead to the Horner syndrome, which is characterized by the meiosis and ophthalmos and ptosis. Only ophthalmic treatment, this is symptomatic treatment which we do for Horner syndrome. So there are certain special situations what we face when you are doing the extended neck dissections. The chances of injury to the brachial plexus when you are dealing with the N3B nodes and the level 5, though it lies very deep to the scalene anterior and scalene medial muscle, but we need to keep this in mind when you are doing this. Especially when you're doing the bilateral neck dissection, when you damage both the marginal mandibular nerves, the patient definitely will have a functional component and droolings. And when the phrenic nerve is damaged bilaterally, which is extremely rare, but this needs to be taken into considerations when you're planning for any neck dissection bilaterally. So ultimately, coming to the end, when following the oncological principles, we do the resections, but we have to emphasize even on the reconstruction and rehabilitation to have the best outcomes for your patients. So, clear understanding of the anatomy, have the better exposure, and identify the proper tissue planes, preserve. The nerves needs respect. So, early rehabilitation in the form of if you have any neuropraxia, if you start early rehabilitation, you can have the best outcomes in terms of rehabilitation for the patients. Thank you. Any questions?
Thank you, Dr. Kranthi Kumar, for speaking out the very
important aspects of the neck dissection. I was stressing upon the anatomy, the variations, which are very important from the surgeon's point of view. Now I request any questions to be raised. Any interactions?
First thing what we learn is the neck dissection. So probably needs to be respected. The nurse needs respect.
Yeah, I completely agree with you. How often do you use intraoperative nerve monitoring in your institute?
Routinely we use it for thyroid, sir, but not in the case of this marginal mandibular nerve. Yes, when I was there in my parent institute in TMH, we had this study. So we started there using it.
Another thing we can do is using loops.
Yes, that armament.
The nerve
yes.
loops, we can just put it so that we don't get confused if it is a bloody field or all that. So it will be easy for us to identify.
Kranthi, I think a comment on the marginal nerve. Like you rightly pointed out, you need to preserve it along the entire pathway. What we have also seen in the study that we did at the Tata Hospital is that 75% of our patients have marginal weakness, which is not being detected and not being documented. And most of the times, the nerve, not only as you said, going up, it also supplies a part of the platysma which goes on to the depressor labile. So, if you preserve these branches, you will not get depression of the lip. And I think that needs to be, you need to focus on that. Dissection all along has to be in the plane below the fascia through which the nerve is going. And for the spinal accessory nerve, I think you would need to encourage everybody to do a dissection with a bipolar, because as most of us who are trained to use a unipolar, the thermal damage of the electrocautery is almost to 1.5 centimeters. So though you are free of the nerve, you might still have some thermal damage.
Yeah, even that study has whatever that Ionian study, at the end of they have documented the amplitude initially with the identified and with the end. They could see a drastic difference even in the selective neck dissection. As you rightly said, it could be because of the thermal damage or traction injuries.
Just to clarify, the loop is not LOUPE, it's the vascular loops, the color loops.
Now, one more aspect of marginal mandibular is the better counseling to the patient attendants. Any of the submandibular or selective neck dissections, inadvertently, sometimes just handling of the branches or marginal mandibularis, invariably the patient will have a little marginal paresis. A smart girl at the end of post-operative period, if she has got this weakness, they will question us. So in fact, the counseling, it makes a lot of advantage, and probably if you have anatomically preserved without damaging, we should assure them it is going to improve in over a period of time, maybe 1 or 2 months. I think this aspect is also very important in the handling of any neck dissection for that matter.
Just one more. In cases of salvage neck dissection, what extra care do we need to take to reduce the nerve? Because the tissue planes are much different.
Especially when you're doing with the 1B, we usually don't face it, sir. But when you're doing with the level 2A, you need to have a proper exposure first. We should not dig it in a small narrow space. Have a proper exposure. Identify your landmarks. Keep the posterior belly of digastric in your view. That serves as the best landmark for any of the dissection in level 2A area. So most of the times we face the difficulty, and then even in the lower aspect, keep the omohyoid always intact. So keep the landmarks preserved.
Thank you.
On a lighter note, we should not have gender bias when we try to save the nerves, whether it's a smart girl or smart boy, we should still save it.
So it must be a smart surgeon.
Whether smart or not smart is immaterial.
Sir, I have one more question. Sir, usually, like many of the surgeons when they operate, they are sure that they have preserved the nerve. Say for example, there was a perifacial node and then you had to delineate the nerve in its entirety. So unfortunately, the patient develops marginal nerve palsy. So are there any post-operative things what you are going to add, or are there any, how would you counsel this patient that it is going to improve, or when do we have any cutoff where we can say it is permanent or any temporary or anything?
Usually you wait whether it is a neuropraxia or not. That's classical how we follow it for any sort of a new nerve damage and all. just wait, see for this whether it is a neuropraxia or sometimes it usually recovers. If it doesn't recover in a period of 3 to 6 months, then you go for a physiological testing and all, then we can find it out. When you do the electromyography, you can get this.
Thank you, sir.